for the talks, and we'll have Dr. Lorenzi from Rouen start speaking about complication in secondary IOL implantation. Thank you very much, and I thank Alistair thank you for joining us for this session, Alistair. It's a real pleasure.
To the Retina Committee and George Caputo for the kind invitation. So, secondary IOL, we have a lot of choice. A lot of choice of techniques means a lot of different complications. First one, decentration is where there is a distance between the IOL center and the optical axis. This is not always a problem, because with the monofocal IOL is not always impairing the visual acuity, but sometimes the rubber can provocate a dispersion of blood or pigment and then make problem. Tilting is when the IOL is not parallel to the iris plane, and the definition is the angle between the IOL optic axis and the pupillary axis, and this can lead to oblique astigmatism and aberration. But it's not our main problem, because this standard patient has dislocation in one eye, and the other eye decentration and retinal detachment. When the IOL position is not perfect, we can have the UGH syndrome. UGH is for uveitis, glaucoma, and ephema. This was described in '78 by Ellison, and the mechanism is the rubbing of the IOL on the iris, and was described initially for the angle AC IOL, and but the modern UGH syndrome is not linked to ephema, but is more linked to vitreous hemorrhages, recurrent vitreous hemorrhages. And another characteristic is the cystoid macular edema that is present in almost 50% of the patients. The pathognomonic sign of UGH syndrome is the iris transillumination. And we can see that the transillumination match exactly the optic of the IOL. And this can help in making differential diagnosis from herpetic uveitis. The management of the UGH syndrome is mainly medical, and we have three components: uveitis, so steroid; glaucoma, any kind of drops, but if we can avoid prostaglandin for inflammation, and to reduce the rubbing of the iris, we can use cycloplegic like atropine once a day. For the edema, prefer topical drops, and remember that intravitreal device like Ozurdex can be dangerous because it can migrate in the anterior chamber. In the case not responding to medical treatment, we have to go to the surgery, try to reposition the IOL, or explantation with or without reimplantation. In the recent review of the literature published by Romano this year, we can see that the macular edema is more linked to iris fixation suture, and other complications like vitreous hemorrhages and retinal detachment are more linked with Carlevale and scleral fixation suture. Another complication typical of the Carlevale lens is the reverse pupil block. The iris is aspirated throughout the IOL and create the reverse pupil block like in pseudo-exfoliation syndrome. And when the Carlevale is at 1.5 millimeter and can be resolved by laser iridoplasty. Another severe complication of all these techniques is corneal decompensation, that is not only visible in this kind of eye with iris claw anteriorly, but also in other techniques, because it's all the maneuver that we have to use for secondary implantation that can lead to corneal endothelial loss. I show a different way to remove an IOL, removing the corneal traumatism using a capsulorhexis forceps and a 1.2 knife. This can allow a very gentle maneuver to remove the IOL. We are publishing this technique on Retina. And finally, some patients accumulate complication. This is an example of a patient that has a malposition of iris claw lens. It was one eye patient because of congenital glaucoma. And we will see the surgery. So the position of the artisan is not good because it's in and out of the iris. And there is a retinal detachment. And when we start the surgery, we see there is a second IOL, not a secondary, but a second IOL that was looks in the posterior segment. So this was some years ago, so I didn't know the technique of the 1.2 knife. So a classical Pacman technique to remove the IOL. And after that, the management of the retinal detachment with the classical vitreous-based shaving. And at the end, when we have PFCL in the eye, we remove the attach of the iris claw from the iris. We try with acetylcholine to have a meiosis, but it was impossible, so mechanical meiosis. And we refix the artisan posteriorly. And that's it. After that, I complete the fluid exchange, and we use densiron oil as a tamponade because I'm an ophthalmic patient. So take-home messages. Aphakia surgery show many techniques because no one is perfect, and no one is critically superior to the others. Complications are not so uncommon. And some complications are typical of a technique, some other are common to all the techniques. Remember that complications are often not isolated. There is some syndrome, there is a patient that has a lot of complications. Always remember to, when you have one, to look for the others. And my suggestion is to try to manage the most of technique you can, and then you choose your best one. Thank you very much.
Inside the vitreous cavity, why take it off and put another one? Let's try to do something with this one. But you can use it also in a phakic eye, subluxated crystalline lens, and if you have a good pupillary dilation, is probably better to see. And you can also kind of quickly use it after complicated cataract surgery. The main challenges are first the long-term stability of the lens and the haptic, and the reduction of its exposure under the conjunctiva. So several techniques and variants have been described. Two main techniques are the chariot technique and the Yamane technique, the one getting the haptic off and then putting them in a sclerotunnel, the other one doing an intrasclerotunnel. So I will detail a little bit. In the chariot technique, you take out through sclerotomies at 3 millimeters to the lembus the haptics, and then you fed them in an intrascleral tunnel that you perform with a needle. So then both haptics are exteriorized and then hidden in this tunnel, and then your lens is fixed. There are variants of this technique using scleroflaps, glue, scleropockets. Many have tried, and it's why Yamane described this technique using tunnelized incisions with a needle, and we stick the haptic inside the needle, doing this both sides, and the tunnels must be at exactly the same angle, exactly the same at 180 degree, to have this perfect centering of the lens and no tilting. Then when you take the haptics out, you have to do it simultaneously, and then you heat the end of the haptic to make a plug, and you put it in. In the original technique, peripheral iridotomy is performed, but that depends also at what distance from the limbus you put. So here are some tips for surgery, and also there is a beautiful study about the biomechanics of the flange haptics. So you have to use high IOP to perform your scleral tunnels because it's quite difficult. And the other tip is to have a really gentle grasp on the haptics. The usual problem here is that you fold or bend the haptics, and then you will have a tilt. When you use Yamane, the inside of the needle matters. Not all needles are the same. You have to use thin wall if you want to use a very small needle, or you take whatever you have, because you have to put it in, but not jam it in, because otherwise when you take them out, it will be stuck in the needle. And also, not all three-piece IOL are the same either. As you can see on the picture, when you heat them, the size and diameter of the plug is not the same. So in this study, they compared the size of the needles and the size of the plug and suggested that we should heat 1 millimeter of the haptic. More doesn't bring anything, less you will have a smaller plug. So 1 millimeter, you just heat it to have a large plug, and you bury it inside the sclera, not just under the conjunctiva to avoid erosion. So what can happen during this technique? Of course, you can have problems. So this is the first time I take it out, and one of the haptics stays in the scleral tunnel. I just put the needle back in, start again. I pass that. The iris looked a little bit smaller. I try second time, and then the other one gets stuck in. So I try again, everything from the beginning, and you can imagine after 3 times, your hand is not so gentle, so now I break my haptic. That's the end of it, but actually it takes 15 minutes. Then you take it out, you put an iris claw if you want. Post-op complications, the main one is dislocation, but as I told you, it's usually is caused by decentration or trauma on the haptics. And the reverse pupillary block, it's lower if you do PI or if you position just a bit further from the limbus, especially in highly myopic eyes, probably 3 millimeters might be better. And the other problem is the haptic erosion. Of course, you will have to see them for their whole life because you are at risk of haptic exposure. But actually, this risk is not so frequent, about 1%. And if you plug inside with the Yamane technique inside the scleral tunnel, you should avoid it. And it's really treatable. You can take it off, retrim, and put it again. What about postoperative outcomes? So usually we aim for in the bag, but if you put it a little bit further, you might have a difference about half a dioptry. Either way, the refraction is stable with a few astigmatism, and there is really, as I said, an importance on how you perform the scleral tunnel. So make sure they are symmetric in length and angle when you do them to avoid any tilting. And a study compared Carnevale lens to Yamane. They had the same decentration and maybe a slight higher tilt degree in Yamane, but it happened also in Carnevale. So take-home messages. I think haptic scleral fixation can be an effective technique when you have the good tips, especially with the Yamane technique. It's quite chic. You do it fastly, transconjunctival, with reduced astigmatism and quick recovery. The eye is almost like white. So the long-term follow-up is needed for the erosion. There is a learning curve, but you always have to be prepared for some tricks. And I will conclude that I think we should all know how to do all the techniques to adapt to the patient. Thank you.
Thank you so much, Elise. I agree that when it's always need to be considered just to try to fix the lens you have. But if you don't, do you usually use this technique?
Like a secondary?
Yeah.
Actually, I usually do the recovery of a 3-piece IOL. So I'm really happy to use this technique. in that case. So I preserve the endothelium and the anterior chamber. And then depends of the mood or what the what the resident wants to do or wants to see. But actually, I put all the 3 techniques. Usually, when I take the lens off, I will put an iris claw because if I open the cornea quite widely, I think it's faster. When I have to put from the beginning, I think Carlovale is a good option, but I don't like just doing all the flaps after failing my first surgery. It's really longer, but I know that Kai is going to tell us it's very quick and effective.
And congratulations for making it out this early hour in the morning. So who's using the Carlovale already? Raise your hands. Right, so after 6 minutes, probably everybody should try using it. These are my financial disclosures. None of them are relevant. So I would like to introduce you to the principle of it, the initial results that we had, different approaches and surgical hacks, clinical results, complications that might occur and how not to have them. And then we'll have to discuss the 2 different types of Carlovale that exists. So, well, the principle is very easy, and the secret lies within the anchor. If you look at that, it's quite self-explanatory. You just take the anchor, you externalize the anchor, and then it will stay within there. So we have this. This is one of my old cases when I went in with the 27 gauge approach. So it's very easy now. It is recommended to use the 3 and 9 o'clock positions, but I don't like using that because there's ciliary arteries at the 3 and 9 o'clock position that come out there. So if you go slightly towards 2 or 8 o'clock, then you might avoid this and might avoid recurrent vitreous bleedings. So what we do in this technique is we use a 27 gauge approach, and we put in the trocars and created scleral flaps or scleral pockets. There's other methods of creating scleral flaps or just doing T-incisions. So you can get basically as creative as you want in order to bury the T-haptics below the sclera. Now during a session yesterday, there was even somebody who was propagating just creating no scleral flap and putting it directly under the conjunctiva. I personally would not go for that, but he said that his results are good. Now it's very important when you externalize the anchor, and we'll spend time on that just a little bit. I think this is very critical. Externalizing the anchor is really the thing that will get you into trouble and will have you frustrated. So really externalizing the anchor. And you see me there, I'm rather pushing in the sclera from the outside than actively pulling it out. Then you suture it, and then it's done. And what you see there as well is that there's this tiny bit left on this video. And I got really lucky to take it out. And after editing this video, I was thinking like, gosh, how did I not see that? Ended up okay though. So we did in a clinical study about that from the first 16 cases, so it's very easy. The 44% of the Euler hypotony during the first 2 days, I would put that down to the learning curve as well. And now the very important thing is the different surgical approaches. So I try to have a frown incision on the scleral part 2 to 3 millimeters away from the limbus, and then tunnel it, creating the scleral pocket, and then pulling it out. Now there is 2 different types that we have. We've got the MDTEC lens and the Soleco one. So the Soleco is the older one. That's a bit more, it's a bit finer and it's a bit more sensitive. So pulling out these anchors is very important. Once you have the MDTEC, and I would recommend that everybody should use that one because it's hydrophobic, the anchors are stiffer and it's harder to take them out. So you can't go for a 27 approach if you go on MDTEC. You have to go with a 25 or 23 gauge sclerotomy. Now, what is also very important for me, what helped me quite a lot, because let's be honest about those anchors. Those anchors will break and it will have you frustrated. And once you manage this situation where the anchor doesn't break, and the worst thing is that the second anchor breaks, and then you have to take out the lens and or suture the lens entirely. So make sure that you are not really actively externalizing the anchor. Make sure to grab it, externalize the forceps that you have, and then you push in without moving your forceps. You just push in the sclera, thus passively externalizing the anchor. And if you do that, if this is the only thing that you take away from this Euretina, I will promise you, you will have a lot of more fun with the Carl Wale lens. I would also suggest that you use two forceps to grab it. I mean, there is very elegant anterior segment surgeons who do it with one forceps and then use a push-pull to just use two forceps and be very gentle about that. Now, this year, in August, we published a study of 280 eyes showing that basically you can use it. It's safe to use. You will have you can run into hypotony, and you can have a little bit of vitreous hemorrhages. This is represent a literature as well. We even had one case of an endothelial compensation, but keeping in mind that we are talking about heavily impacted eyes that had problems before. I think this is a rate of endothelial decompensation that is acceptable. Now, complications, let's talk about it. The anchor breaks. There's the lucky break that you just break one part of the anchor off, resulting in this. If you have that, just go ahead with the surgery and externalize the anchor, maybe put in one suture, that's it. And then there is the unlucky break, if the entire thing comes off and you are left with that, and then you really have to think about what you do. I would personally recommend to exchange the lens now, but there's always the possibility to put in a 10-0 suture, and then you have a sutured lens. Now, let's talk about the two different types of Carl Wale that we have, because it's very important. So you've got the Soleco one that is hydrophilic, and then you've got the MD-Tech one that is hydrophobic or has a hydrophobic coating. Now, why is that important? I think it's very important that we only use the hydrophobic lens, because hydrophilic lenses are known to cause problems, opacification. And if you put in a lens, for example, a sclerally fixated lens in an eye that is problematic, you are working on an eye that will have a tendency to have a retinal detachment or an endothelial decompensation. So you want to have a lens that is actually a lens where you can put in a gas tamponade without being opacified. Of course, unless you want to do the surgery all over again. And very, very actual case report that came out. I have been talking about that quite a lot, that you shouldn't be using the hydrophilic one, and now the first case report came out with the opacification of the hydrophilic one. So just don't use it. Use the hydrophobic ones. We are VR surgeons, and we should be very aware of that fact. So the Carl Wale itself is an on-label solution. It's very good. You will have to deal with the anchor breaks once you start operating with that, but once you have that, it's good. It's centered, you have good refractive results. Be within the hydrophobic lenses if you can. There's different techniques, whatever works for you, and we are still waiting on the long-term data. So the Carl Wale itself is an on-label solution, it's very good. You will have to deal with the anchor breaks once you start operating with that, but once you have that, it's good. It's centered, you have good refractive results. Be within the hydrophobic lenses if you can. There's different techniques, whatever works for you, and we are still waiting on the long-term data. Now, regarding the long-term data, there's just one thing that I would like to say, because we are dealing here with a synthetic material that is in interaction with the biological material. So we have a tendency, and you will probably see that, and I'm not sure to where it comes, that you will have anchors working through the conjunctiva or something like that. Thank you.
Others. So I'm going to talk about 4-point scleral sutured lenses, and I'm also going to pick up on what Elise said. I think actually it's important to know more than one technique, because these patients are heterogeneous and there isn't one technique that's going to do all of them. So who do I use these in? So obviously patients with no capsular support. You need some mobile conjunctiva, and you don't want very thin conjunctiva because you need to overlie the Gore-Tex suture. I certainly like them in younger patients when anterior chamber lenses and Carnivale lenses, for various reasons, might not be applicable. As Kai said, if you think they're going to have retinal detachment surgery, then I personally prefer a 4-point fixation versus a 2-point fixation. I also tend to use these quite a lot with corneal graft patients. So I receive quite a lot of referrals from the anterior segment service when they have decompensated corneas, that they want the lens surgery to happen before the grafting surgery. And that, again, limits you according to what kind of lens you can put in. I don't use them if you've got very thin sclera. I don't use them if you've got a history of scleritis. And if you've got a lot of conjunctival scarring or thinning, then again, they're not the ideal type. So I thought I'd just take you through the key steps so that actually day one you could do one of these. The most important thing is that you cannot spend too much time in preparing the eye to get the absolute markings in the exact right places. So everyone said it's really important that they're exactly 180 degrees away from each other. It is really important that you do a good conjunctival peritomy with no buttonholing and right down to the scleral layer under the subtenons. And the other thing is the marking of where you do your sclerostomies is absolutely essential. I always have 2 calipers, one caliper set at 2.5 to 3, which is the distance back from the limbus, and the other caliper set at 5, which is where the 2 entry and exit points sit. And then I don't change those at all throughout the procedure. It doesn't matter too much exactly what you choose, it's just that it's consistent in both sides. I also use the caliper itself to hold the eye in position so that I am absolutely sure that when I do my sclerostomy, it's exactly where I want it to be. So in essence, these are quite straightforward. You suture the lens from above to below and up and down. This is the way that you prevent the Gore-Tex suture from rubbing on the iris. You first externalize the Gore-Tex suture on the nasal side, or the more difficult side in terms of access. This is 23 gauge, but I use 27 gauge routinely now. Then you fold the lens. This looks easy, but it can be quite frustrating at times. Insert the lens, and then you externalize the temporal Gore-Tex. And I'll take you through some individual parts of this now. So, folding the lens, this looks the easiest bit, but actually what can often happen is that the lens slips off and unfolds just when you want to do it. So here you go, this is someone trying to do it. You keep going, keep going. So the way in which to make sure you do that is to make sure that you're, here we've got an iris repositor, make sure that it's along the length of the lens as much as you possibly can. And you need a counter traction, so you're pushing up with your iris repositor and down with your forceps. And the other thing is to make sure is that you actually make your corneal section big enough. You don't want a really tight section, because the last thing that you want is when you finally get there, you can't actually get it in. And here again, you can see how if you don't go right the way along the length, the flanges here open wide and you can't get it into the eye. The other thing is you need to be meticulous about your sutures. Don't allow them to all overlap, otherwise you end up with this cat's cradle that you've got in here, and then you don't know where you're at, you don't know which part comes out where, and you have to take it out and start again. Trying to undo this in the middle of the eye is never going to work well. The next thing you need to do is to make sure that your lens is as central as possible, and you need to adjust your sutures on either side till you get it in the right position. What you need to be aware of is that a slight decentration is much more acceptable in terms of visual outcomes than over-tightening and trying to correct it. So if you do slightly push the lens to either a nasal or a temporal edge, don't worry about it, because the iris will probably cover it up. But don't try and correct it by over-tightening the other suture, otherwise you'll get curvature on your lens, which gives you a worse outcome. You can see the effect here, where a lens has been put too tightly, and you can see as we cut it, how this springs back and these flanges here open up. And that is what caused a tilt in the lens, a curvature in the lens, and made the vision poor. So don't be tempted to do that. The other thing that is absolutely vital with these lenses is you have to bury the knot. You cannot leave it on the scleral surface, and you have to make sure that you bury it properly. If the suture ends are still sitting in the wound, they will cause areas of scleral thinning, as you can see here. It's also important not to touch the suture as much as possible with your forceps, because you'll cause compression injuries to your suture, as you can see here. Back to the thing of hydrophobic versus hydrophilic. There is a hydrophobic version that you could use. This is a micropure lens, which I've used to great effect. Works exactly the same as an acryos, and you can use in patients that you think might have detachment surgery. Why do I think VR surgeons should do this versus anterior segment? Well, sometimes you get surprised. So, for example, here we've got a patient who had a retinal detachment that we hadn't seen because they had an opacified lens that we couldn't see the periphery. And then this is one of those heart sink cases where I've gone in, and this is a corneal graft patient, as you can see, a combined corneal graft and lens, and I've just come through, and the forceps is broken in half in the patient. That bit's now dropped to the back of the eye, and the view's very poor, and now I've got to pick up the bit of broken forceps and bring that out, and then externalize it. So VR surgeons are definitely the people to do these things. Thank you for your attention. This is just a bit of a fun whilst people are asking questions, but if you do happen to, as you know, whenever you do a technique, you always see every complication. And this is where I thought I'd done a fantastic job, pulled everything through, and actually managed to pull the suture straight back through the lens again. So I ended up having to resuture it in the eye. And it's perfectly doable to do if you ever manage to do that. Thanks very much.
Thank you for the invitation, although I must say Professor Nuits was supposed to give this lecture, but he has a family emergency, so I'm taking over from him. Indications for correction of aphakia are well known. First of all, complicated cataract surgery, reduced capsular support, zonal damage, drop nucleus are all reasons for doing aphakia correction. Also, dislocation of the IOL, including in the whole capsular complex, is one of the reasons for it. The other reason for doing aphakia correction, for example, in congenital lens malformations like Marfan syndrome or Wells syndrome. There are a couple of options. Anterior chamber, which is an option which is, well, gone out of fashion, mostly because of complications with endothelial loss. For example, the last Alcon lens, the Cachet lens, was retired over 10 years ago, and it's no longer accepted here in Europe. The other option, well, you see a lot of options my colleagues presented with transcranial or fixations, and now we're also going to talk about iris fixations, IOLs. This is a presentation of, for example, a 44-year-old male with a Marfan syndrome. He had a decentration of the lens, finger counting in one eye, 20/200 vision in the other eye, and the plan was to do a lensectomy, later followed by artisan aphakia implantations. After the lensectomy, the vision was corrected with plus 14.5 and a cylinder on both sides, but the vision corrected was very well. The artisan aphakia lens is a lens which Jan Worst proposed in 1972. It has remained with slight modifications over that whole period in basically the same form. It is a mid-peripheral iris fixated, non-foldable PMMA IOL. It has no problems with sizing in the form that you just place it over the pupil. There's no reason to place it in any direction. You can place it in any direction you want, just as long as it covers the pupil. It is available in diopter ranges of 2 to 30 in steps of 1 diopters, and between 14.5 and 24.5 it's also available in steps of half a diopter. The Diameter of the optic is 5.4 millimeters, so that's also the minimum incision size you're going to have to use. It has a convex position to make sure there's a slight space between the pupil and the iris. It has a constant of 115.3 for anterior chamber implantation and a 116.9 for retropupillary implantation. There's also pediatric sizes, which are 4.4 millimeters in diameter and slightly bigger in the overall. And toric aphakia IOL is also available up to 4 diopters. The multifocal version is not yet available. We advise 3 different instruments. First of all, the artisan implantation forceps, which is a forceps without any serration, so you have a very atraumatic implantation and no chance of scratching the optic. You've got the artisan manipulator to actually put it in place, and we propose to use the artisan enclavation needle to make sure you can actually fix the haptics. It was proposed to use this lens in the anterior chamber. Recently, or in the last 10 years, it has been proposed to actually use this lens more and more in the posterior chamber, and both work very well, and it doesn't really matter in which direction you actually place it. So also with a deformed pupil or an asymmetric pupil, you can just fixate it quite fine. This is the surgery. Accurate incision has been made in advance. Superior, there is a what we always suggest is putting your paracentesis on the upper side, so you can actually have a good visualization of the haptics, bringing in the optic with the implantation, then turning it, and because of the placement of the paracentesis on the superior side, you have a good visualization of where you actually do the enclavation of the haptics. This is what we always propose, and especially don't use the 3 or 9 o'clock, because you're going to lose sight of where your haptics actually are, because you're compressing the cornea, which will give you some folds and you lose sight of it. Enclavation of the other side. And that's basically it. Afterwards, we always use carbachol or myostat. Yes, you'll see some ovalization of the pupil, but this is just temporary, especially when you use the myotics, which will go away as soon as you have a normal dilatation of the pupil again. 8 years later, vision has been stabilized with a very nice refraction, stable endothelial cells, and if we look at the long-term data on stabilization of the refraction, you see that all refraction is within the 1 diopter range with good visual outcomes. The biggest complication with these iris-fixated lenses is corneal cell loss, which especially in the first 3 years may end up to 10% and then a 2% decrease over. These iris-fixated lenses is corneal cell loss, which especially in the first 3 years may end up to 10% and then a 2% decrease over time. There was a large study done to look at anterior or posterior implantation. No differences were found. There was a large study done to look at anterior or posterior implantation. No differences were found. Also, a large study was done to see if, for using this lens with children, especially compared to scleral fixation, both had basically the same outcome, but the use of an artisan was seen as being a far faster surgery. In conclusion, secondary IOL iris claw lens implantation in aphakic eyes appears effective, predictable, and very safe. There is an anterior endothelial cell loss of around 2 to 3% over a year, and especially with children, this is something which needs to be taken care of. As compared to the scleral fixated, surgery time is very fast, but we also see the need for a longer prospective long-term study to compare anterior and posterior iris fixated lenses, and especially compared to, for example, the Yamana technique. I just want to have a small remembrance of Professor Worst. He is also a Dutchman who actually invented this lens over 50 years ago. Thank you very much.
Thank you very much, Igor. There was a question about iris clipped, a question that was addressed to me about iris clipped in young patients. It's true that we do not recommend to use iris clipped in children, never anteriorly, extremely rarely posteriorly, because of the risk of trauma, dislocation. I mean, we've followed even many eyes with sutured iris sutured IOL, and they end up in almost all the cases subluxating after a few years.
Any minimum age for that?
What, like in Marfan syndrome, what we do is we start just removing the entire lens with the capsule with an anterior approach, anterior vitrectomy, and we wait till the child is maybe 7, 8, 10 to consider IOL implantation, and in those cases we use or sutured IOL or eventually Carle in older patients. So we really don't recommend that. I have a question for Louisa. You use only Gore-Tex. Do you feel really comfortable leaving such a thick Gore-Tex thread subconjunctively? And because, I mean, Prolene works very well. The only consideration is that with time, the suture won't alter, but it's just that the suture will, I mean,
I am comfortable with, I mean, I suppose it's used in valve surgery, so I suppose we've got good long-term evidence that it is stable, and so it's used in cardiovascular surgery as a suture that remains in place for valve surgery. So as a substance or as a material, I think we've got good evidence that it works well and it will stay long. Sorry? Well, yeah, and that's why we got the Prolene suture breakages over time, didn't we? And it's like all these things. I think we've got to be really careful, haven't we, with these, because the time of follow-up we need to understand the long-term implications of what we're doing here are long, isn't it? It's not really 5 years, it's 15, 20, 25 years. So you're right, and I think it's really important that when we're consenting our patients, that we do let them know that they are complex patients. We are doing a lens that is not in its position that is most of those lenses have been designed for, and we can't guarantee that in 15, 20 years they may not be back with us needing something else being done.
And you get an excellent, stable lens. and it's durable. I agree that sometimes we need to lead with the sutures. So.
And the only other thing I'd say is we've got to remember that as much as we love operating, in some cases, just a contact lens would be a perfectly good option for our patients, and we need to make sure that when we're doing our consenting process that all the possible options are put before them.
So Kai, what's the learning curve, honestly, do you think, on the Carnevale lens? Because I didn't really get up it very well.
The biggest problem with the Carnevale for me personally, it's I always call it the first try bomb, because the first try goes well and you think like, wow, and then after you've done 15 or 20, you start breaking the anchors and you get frustrated a lot. So I would say it's very steep, so you land the first ones really well, and after 15, 20, you get into trouble with the anchor. I would say that this stops after doing 50 or 100.
Okay. Yeah, that's a lot of unhappy patients. Igor, we're making comparatively big holes in the cornea of eyes that have often had previous surgery, complicated phacos, they've had previous tunnels. Any sort of little top tips on how we should avoid astigmatism? Because this and cystoid macular edema, for me, are the guilty secrets about secondary lens implantation.
I always go for the scleral approaches in the form that I place my incision far back. So I really go for the old school scleral incision. So I open the conjunctiva and do the full 5.5 millimeter scleral incisions. So to be really back from the cornea. I usually do my artisan lenses with drop nuclear or dropped IOLs. So I'll do a full vitrectomy and I always place them on the posterior side. One also thing, since I've been placing them on the posterior side, I have stopped using the iridectomy. And I've not had any problems with those ever. Yeah, the only time when I saw any pupillary blocks was when one of my colleagues actually put it on the front again and forgot to make the iridectomy, and the next day, yeah, the lens was in the endothelium, of course.
I guess it might be that it's quite a big optic relative to the pupil size. In that respect. So, and when you're doing these scleral tunnels, in order to reduce the astigmatism, how far into the cornea are you coming out on the corneal side, on the endothelial side?
Just barely where you actually see it, so you come very close to the place. Placing them on the posterior side, I have stopped using the iridectomy, and I've not had any problems with those ever. Yeah, the only time when I saw any pupillary blocks was when one of my colleagues actually put it on the front again and forgot to make the iridectomy, and the next day, yeah, the lens was in the endothelium, of course.
I guess it might be that it's quite a big optic relative to the pupil size in that respect. So, and when you're doing these scleral tunnels, in order to reduce the astigmatism, how far into the cornea are you coming out on the corneal side, on the endothelial side?
Just barely where you actually see it, so you come very close to the plane of the iris, actually.
And dealing with iris prolapses with that, if you're near the iris root?
Well, I usually do those when I also have my vitrectomy also already done, so I switch off my infusion cannula, of course, and at that point you have a very stable, also stabilized anterior chamber with viscoelastic, so there's no flow, so you can just slide it in.
And then I think a last one, somebody's asked, how much vitrectomy should we be doing with these lenses? Because the vitreous can end up mysteriously, it wasn't there at the end of the op, but then there's a little peak pupil and it doesn't look quite as neat as you thought it was. So should all of these have a full PPV, or should it be just a little anterior clear up? Anyone? Igor?
If I do them with a dropped IOL or a dropped nucleus, I do a full vitrectomy, usually also with a prophylactic laser.
I always had a problem with the concept of anterior vitrectomy, because I never understand when it stopped the anterior and start the posterior vitrectomy. So to me, a vitrectomy is always fall, is we can judge fall without avoiding maybe a very precise shaving of the base, but I do a complete vitrectomy.
Elise, last comment?
Yes, for Yamane technique, I think a full vitrectomy is mandatory because you work quite close to the base, so I would not risk it. Yeah, full vitrectomy.
Okay.
You had a couple of other comments.
Yeah, I would like to ask, actually, all of you. The problem is also we are talking here, I ask Kai, he has Carlevale, all the dioptries in his OR, we don't. It's about the needles, but I think we need to know what is available, so that's why Carlevale has also a cost. So we need to consider everything. I think I don't think everybody here has Carlevale lens Gore-Tex in the OR. So that's why also the using of 3-piece IOL intrascleral could be useful if you don't have anything else.
Okay. Thank you so much. I know there are many questions. I'm so sorry we are over time. It's very important to keep the timings. Thank you for all your tips. Thank you for the excellent lectures. And let's continue. Thank you so much.